Hey everybody, today we're going to be covering chapter 37, so we're going to be reviewing obstetrics and care of the newborn. In this chapter we're going to go over the anatomy and physiology of the obstetric patient or that of the pregnant patient. We'll cover antepartum or pre-delivery emergencies. We'll cover how exactly a normal delivery occurs, some things that occur within an abnormal delivery, as well as how do we care for a newborn child. During this lesson, you'll learn how to recognize and provide care to these patients for both obstetric as well as gynecological emergencies. Now, childbirth all on its own is a natural process. They don't really need our help. If this is going to be a normal pregnancy, there's no issues. There's nothing we have to do except for pretty much just catch the baby as it comes out of the vagina. Now, on occasion, you will deliver. There's many EMS personnel out there that if you ask them how many deliveries that they've done in the field, there's quite a few that say they've never delivered in the field. Me being one of them, as I stand right now on March 14th, 2019, I've had a few close calls, but I've never delivered. Now there are complications that could occur. These aren't common, but we have to be prepared to manage them when they do occur, so that way we can ensure that not only that the baby will be okay, but the mother will as well. Now, reviewing some of the stuff that we've covered previously, within a female patient, you have your ovaries. This is where the eggs are released that, pending there are sperm there, would become fertilized as it goes down the fallopian tubes. Your fallopian tubes is that point of fertilization, as well as transporting the ovum being a fertilized egg, would then be transported down to the uterus. Now your uterus, it's actually a pear-shaped organ that would contain the developing fetus. It is split up into three sections. You have the fundus, the body, and the cervix. Fundus being the top, body being the body itself, and the cervix being at the bottom. Now your cervix also contains a plug of mucus that seals the uterine opening during pregnancy, preventing any contamination from entering the uterus. Once the cervix begins to dilate, this plug is discharged, and it appears as a pink-tinged mucus within the vaginal discharge. The expulsion of the plug signals the first stage of labor and is known as the bloody show, also called the water breaking. When patients state that my water broke, that's that plug being broken and it discharging. Now within the uterus you have three layers. You have the endometrium, the myometrium, and the perimetrium. If y'all remember back to our previous lectures, specifically during the medical chapter, the endometrium is the actual layer that is sloughed off during menses and is passed and recovers in preparation for the next cycle. The placenta, this is an organ that develops as the patient is impregnated, and it attaches into the inner uterine wall. This is a very highly vascular organ, and what it does, it allows for the baby to get any nourishment it needs, oxygen, food, blood, and waste removal. Now the actual blood of the fetus and the blood of the mother do not mix, except during birth or miscarriage. Once the baby is born, the placenta separates from the uterine wall and is delivered as the afterbirth. Now your placenta, it contains one vein and two arteries in an arrangement that is covered by a protective substance called Wharton jelly. This is what makes up your umbilical cord. These vessels within the umbilical cord are unique in that the vein is carrying oxygenated blood and nutrients to the fetus, and the arteries are carrying deoxygenated blood and waste products back to the placenta. The structure of the cord and the blood traveling through it keeps it from becoming kinked and occluding blood flow to the baby and back to the mother. You also have the amniotic sac, which is filled with amniotic fluid in which the baby floats within. What it does, it insulates and protects the baby throughout the pregnancy. This sac contains anywhere from 500 to 1,000 milliliters of amniotic fluid, and this could potentially rupture at the beginning of labor. You also have the vagina, which is the lower portion of the birth canal and is the actual portion that the baby travels down during pregnancy. As the fetus moves down into the vagina, the head of the baby causes the vaginal walls to bulge, especially during a contraction, and the top of the head appears at the vaginal opening. This is known as crowning and is a sign of immediate delivery. Let me get my pointer. Alright, so here's your fundus, as well as the placenta. Okay. Now, what is some of the conditions that can occur from the placenta separating early? Right. Abruptio placenta, placenta previa, very good. Alright, so here's your fundus, the uterus that the baby is contained within. You have amniotic fluid that's within to help keep the baby safe. You have your urinary bladder that the baby is literally pushing right on top of. That's why a lot of pregnant mothers tend to have to go to the bathroom quite often. Here's the cervix, and once there would be a plug here up until the point that the baby's ready to be born, and then once they're ready to be born, all of this dilates, so that way the baby can then pass down the vagina through the birth canal and be born. Now every month, the female patient goes through a menstrual cycle. These cycles average 28 days. Some have more, some have less. You have some female patients that go through a cycle every other month. This is controlled by the hormones estrogen and progesterone. Now, the first day of the cycle is when menstruation is occurring and the endometrium is being shed, and that's when they have the spotting and the bleeding. Once menstruation is completed, or after it's done, the endometrium is now being rebuilt. On day 14 of the cycle is when ovulation occurs. So this is when the ova, that unfertilized egg, is coming down the tube, coming down the fallopian tube, where it would be fertilized pending there is sperm there. Once fertilization occurs, the ovum is then implanted into the newly rebuilt endometrium, and the cycle of life begins. Or, excuse me, the cycle of birth begins. The cycle of pregnancy begins. Once the ovum has become implanted, you now enter the prenatal period. For the first 14 days of the prenatal period, the fertilized ovum is called in the pre-embryonic phase. If you would try looking at it under a microscope, all you would see is cells. Now, there's a lot of electrical activity occurring, a lot of mitosis and meiosis occurring as the ovum is continuing to grow. And it continues to progress from all the way up to day 15 to 8 weeks. This is the embryonic phase. So now it's an actual embryo. If you would look at it under a microscope around week 2 or 3, it'd be about the size of a peanut. Once the baby reaches 8 weeks, all the way up until birth is known as the fetal stage. And then once they are born, the baby is called a neonate. Now, a normal pregnancy lasts approximately 9 months or 280 days. Some are longer, some are less, and we'll cover that here shortly. Now, a pregnancy is also referred to as gestation. Gestational age refers to the age of the fetus in weeks, from the time of fertilization of the ovum through delivery. So if we're looking at the gestational age of that fetus, if they are 8 weeks pregnant, gestational age would be 8 weeks. Now, during the pregnancy, they break it down into a trimester. One trimester is a 3-month period of that 9-month pregnancy. Now, you also have some physiological changes that are occurring within the pregnancy, which is being caused by all the hormones that's being released to help develop this fetus, the increase in metabolic rate, because now the mother is not only having to eat and produce energy for herself, but also for that unborn fetus. So there's a quite number of body systems that are affected. For example, within the reproductive system, the uterus is substantially increased in size because it's having to grow. It's growing a baby in it, so it can't stay its normal pear shape. As that baby is continuing to grow, the uterus is, because of as it continues to grow, it's very vascular. And as it continues to grow, it can hold up to 1/6 of the mother's blood volume at any time. Now, the pre-pregnant uterus weighs approximately 2 ounces and holds only about 10 milliliters of blood. At the end of pregnancy, 10 milliliters of fluid, not blood. At the end of pregnancy, this uterus now weighs more than 2 pounds and holds 5,000 milliliters of fluid. The pregnant uterus, as I said, is extremely vascular and contains about 1/6 the blood volume of the mother. You have that mucus plug that's forming in the opening of the cervix to help protect the fetus from infection. And also the breasts are enlarging and becoming more nodular in preparation for lactation or milk production. Within the respiratory system, because remember, now the mother's not just breathing for herself, she's breathing for that baby. So now her oxygen demand is increasing. The respiratory tract resistance decreases as a result of hormones, causing smooth muscle dilation. So the bronchioles are dilating even more to let more air in. The patient's tidal volume is increasing now by 40%. Even though tidal volume is increasing, the actual functional reserve volume is decreasing, meaning the patient has less of a respiratory reserve. Because she's breathing more, those bronchioles are opening up more. So now even though there's more room for reserve air, residual air, because of that increase, that residual air is also being used. Within the cardiovascular system, the maternal blood volume is increasing by about 45%. There's also an increase in the red blood cell content as well as plasma. However, the plasma volume increase is greater than the red blood cells, causing a relative anemia within the mother. That's why pregnant patients are instructed to take prenatal vitamins, which contains iron supplements to increase oxygen binding on red blood cells. This blood volume increase delays the signs and symptoms of shock within the pregnant patient. So that's why we need to monitor their vital signs. Now keep in mind their heart rate as they become further along will increase by 10 to 15 beats per minute, and their blood pressure will decrease within the first 2 trimesters and eventually return to normalize within the 3rd trimester because at this point the fetus is not growing as much. It's pretty much for the most part at its max size. So it's not having to pump out more blood, if that makes sense. Within the gastrointestinal system, patients become very nauseous, and vomiting commonly occurs specifically during the 1st trimester as a result of the various hormone changes and the change in the need for carbohydrates. There's also a decrease in peristalsis, or food being digested properly because of the fetus growing within. So now bloating and constipation is another possible effect that the pregnant patient may have occurred to them as well. Within the urinary system, because now there's more waste being produced, renal blood flow is increased to help filter out the waste byproducts. So now filtration is having to increase also by approximately 50% during the second trimester and remains elevated all the way through birth. There's also an increase in urinary frequency during the first and third trimester because of the uterus compressing down onto the bladder. The urinary bladder is also displaced superiorly as well as anteriorly because of the uterus growth, thus causing an increased chance of injury due to the bladder because of this. Within the musculoskeletal system, the pelvic joints are loosening because of hormones to help make room for that fetus to go through the pelvic girdle to be delivered. Also, the mother's center of gravity changes because of the heavy uterus. As the uterus continues to grow, the patient compensates for this by leaning back and therefore often experiences lower back pain. All right, some pre-delivery emergencies that you may come across. One of them is hyperemesis gravidarum, which is extreme morning sickness that the mother can have. The symptoms of this usually occur between 4 and 6 weeks of pregnancy and can peak between weeks 9 and 13. And this is all because of the hormone levels causing the severe nausea and vomiting. They may also have excessive salivation, weight loss of 5% or more of the pre-pregnancy weight, confusion, fatigue, headaches, hypotension and tachycardia because they're becoming dehydrated, anxiety, jaundice because it could potentially even cause liver damage. Care for this is primarily supportive. Pretty much we just treat the symptoms as they occur, monitor our ABCs. If the SpO2 is less than 94%, or if poor perfusion and hypovolemia from severe dehydration are suspected, go ahead and supply oxygen. Also, it's important to distinguish this condition from typical nausea and vomiting associated with pregnancy. You may also have some conditions that could possibly cause hemorrhaging. If bleeding occurs behind the placenta where the margins of the placenta are intact, there will be no vaginal bleeding, even though the patient can lose a significant amount of blood and present in hypovolemic shock. This hemorrhage could be life-threatening depending on the severity, and causes of this could include spontaneous abortion, placenta previa, abruptio placenta, ruptured uterus, and an ectopic pregnancy. Spontaneous abortion or miscarriage occurs when the fetus and placenta is delivered before 20 weeks of gestation. The cause is usually genetic. In approximately 50% of cases it's genetic, or it could be caused due to some type of uterine abnormality, infectious process, drugs, or maternal disease. Usually these patients will present with cramping and vaginal bleeding, are usually present at about 8 to 12 weeks of gestation. The spontaneous abortion is a naturally occurring expulsion of the fetus that is generally related to a genetic abnormality. An elective abortion is the termination of the pregnancy in a medical setting upon the mother's request. Any tissue that is retained within the uterus following a spontaneous abortion could potentially lead to severe bleeding and infection. So we want to transport any patient with a suspected spontaneous abortion. Emergency care for these patients, we're going to provide symptomatic care, treat for shock if the signs and symptoms of it are present. And you want to provide emotional support to the mother and members of family throughout treatment and transport. These patients could potentially be going through intense grief over the loss of the pregnancy. This is normal and expected in both parents. The most significant danger to the patient is severe bleeding from the point where the fetal tissue separated from the uterus. Another antepartum condition that could cause hemorrhaging is an ectopic pregnancy, in which the fertilized ovum has implanted somewhere outside the uterus. Most commonly is within the fallopian tube. What happens is the tissue that's surrounding this developed embryo ruptures. Now, there are some predisposing factors for an ectopic pregnancy, such as a previous ectopic, pelvic inflammatory disease, adhesions from surgery, including the fallopian tube, tubal surgery, including an elective tubal ligation, as well as an intrauterine device. As I said, most ectopic pregnancies occur within the fallopian tube, where it implants within the tube. It could also possibly implant outside the uterus, down here within the cervix, or within the abdomen, actually outside of the abdominal cavity. Ideally, it would implant somewhere along here or here on the sides, but you don't want it to implant down here at the bottom of the cervix. These patients will present with dull, achy pain, shoulder pain referred, vaginal bleeding, tachycardia, discoloration around the umbilicus, a palpable mass within the abdomen, as well as decreased blood pressure. Primary treatment for these patients is to administer high concentration oxygen, regardless of the SpO2 reading and oxygen status of the pregnant patient, via non-rebreather at 15 liters to maximize oxygenation of the fetus. Because if it's a ruptured ectopic pregnancy, she could potentially be bleeding internally. So we want to get as much oxygen as we can. We then want to transport the patient to the facility that can manage a surgical emergency. Placenta previa is when the placenta has implanted near or over the cervix. Now, the mother can go through the pregnancy process. However, as the cervix begins to dilate, it can cause excessive bleeding, and it will be painless. That's why it's called, easy way to remember, placenta previa, painless. Okay. You can have total hemorrhaging, partial hemorrhaging, or marginal. Some predisposing factors is multiparity or more than 2 deliveries. So she's about to deliver twins. Rapid cessation of pregnancies, older than 35 years of age, history of early vaginal bleeding, as well as bleeding immediately after intercourse during pregnancy. For these patients, you want to anticipate and treat for possible shock as she goes through the birthing process. So as I said, ideally that placenta should implant up here. However, the placenta has implanted down and near the cervix, and as that cervix begins to dilate, it causes rupturing of the placenta and it begins to bleed out into the vaginal canal. Major concerns are the blood loss for the mother, as well as hypoxia and distress for the fetus. This is a situation in which, regardless of SpO2 reading and oxygenation status of the patient, high concentration of oxygen is administered via non-rebreather at 15 liters to maximize oxygenation of the fetus. Abruptio placenta is an abnormal separation of the placenta from the uterine wall prior to delivery. So now the placenta is implanted in the proper place, but now it's separated early. Bleeding is occurring from the arteries between the uterine wall and the placenta, and the bleeding separates the placenta from the uterine wall. In a complete abruption, the placenta completely separates from the uterine wall. Complete abruptio placenta does carry a 100% fetal mortality rate. In a partial abruptio placenta, the placenta is partially torn from the uterine wall. Because it remains partially attached, it is associated with a 30 to 60% rather than a total fetal mortality rate. The type of abruption cannot be distinguished, therefore it's important to transport any patient with suspected placental abruption. Predisposing factors for an abruptio placenta are hypertension, use of cocaine or other vasoactive drugs, preeclampsia, multiparity, previous abruption, smoking, premature rupture of the amniotic sac, diabetes, or even trauma involving the abdomen during pregnancy. Because the head of the fetus could potentially block a large amount of blood flow from the vaginal opening, use the clinical signs and symptoms of shock to gauge the severity of blood loss. These patients will present with abdominal pain, vaginal bleeding, contractions, tenderness, abdominal tenderness upon palpation, signs and symptoms of hypovolemic shock if bleeding is severe or is occurring over a long period of time. Care for these patients pretty much the same as that for placenta previa. Primary treatment is to administer high flow oxygen regardless of O2 reading and oxygenation status of the patient via non-rebreather at 15 liters to maximize oxygenation to the fetus. Ruptured uterus. This results in severe maternal hemorrhaging as well as fetal distress and requires immediate surgery. When this happens, the actual uterine wall is rupturing, thus possibly releasing the fetus into the abdominal cavity. This has a high mortality rate of not only the fetus, but as well as the mother. As the uterus enlarges during pregnancy, the uterine wall becomes extremely thin, especially around the cervix. Patients predisposed to this might have a history of uterine rupture, abdominal trauma, more than 2 births, because the uterus each time it's having to dilate for the birth and then recontract. It becomes thinner and thinner. A large fetus, the prior C-section, vaginal bleeding, tearing or shearing sensation within the abdomen, and you might even be able to palpate the fetus through the abdominal wall. Primary treatment, same as with Abruptio and Placenta Previa. Administer high flow oxygen regardless of their O2 sats. Monitor for signs of shock and transport the patient to a facility that can manage a surgical obstetric emergency. Seizures during pregnancy can possibly result in maternal injury, hypoxia, hypercarbia, increased intracranial pressure, acidosis, hyperthermia, and possibly even abruptio placenta. Death of the mother can also result from cerebral hemorrhaging, respiratory arrest, kidney failure, or circulatory collapse. The fetus will most likely experience hypoxia during the seizure because the mother is not breathing. Seizures can also be associated with hypertensive emergency eclampsia. We want to provide the same type of care as we would for any other seizure patient, and transport the patient on their left side or with their right hip elevated at least 15 degrees to the left if they're greater than 20 weeks gestation to keep the fetus off of the inferior vena cava, so that way blood flow can still come back up into the heart. If the patient has a lower blood pressure prior to pregnancy, an increase in their systolic blood pressure of greater than 30 millimeters and a diastolic greater than 15 above baseline blood pressure is used to define the condition. Usually, if the mother has hypertension that is pregnancy induced, it will resolve upon delivery of the baby. Preeclampsia and eclampsia is a hypertensive type emergency. And preeclampsia does frequently occur within the last trimester and is most likely to affect women in their 20s who are pregnant for the first time. Once it develops into eclampsia, this is the more severe form, and is when the mother is likely to go into a comatose state or even go into seizure-like activity. The cause of preeclampsia itself is unknown. However, it is thought to be a result of a vasospasm, increasing the mother's blood pressure and decreasing blood flow to the uterus. Preeclampsia typically occurs within the last 10 weeks of pregnancy, during labor, or within the first 48 hours after delivery. In fact, preeclampsia can occur up to 2 weeks post-delivery. Risk factors in pregnant patients for developing preeclampsia include hypertension, diabetes, first-time pregnancies, pregnancy with multiple gestations, such as twins, triplets, or more, history of previous preeclampsia, obesity, poor nutrition, diabetes, and even connective tissue disorders. These patients will present with altered mental status, hypertension, blurred vision or spotty vision before their eyes, edema to the face, fingers, legs, or feet, epigastric abdominal pain or even right upper quadrant pain, decreased urine output, and even a severe persistent headache. They may even have signs of pulmonary edema such as crackles upon auscultation, respiratory distress, and an SpO2 reading of less than 94%. Supine hypotensive syndrome. This is compression of the inferior vena cava. When the patient is in a supine position, it is reducing blood flow to the right atrium because now the fetus is lying on the inferior vena cava. This decrease in the preload reduces stroke volume and in turn reduces cardiac output. This decrease in cardiac output reduces systolic blood pressure as well as perfusion of the patient. They'll present with dizziness, lightheadedness when in a supine position, tachycardia, cool clammy skin, and decrease in blood pressure. Because the signs and symptoms of supine hypotensive syndrome mimic those of hypovolemia, it's extremely important to assess for any possible blood loss as the cause of this condition as well. Treatment for these patients is to place the patient on their side or elevate their right hip 15 degrees. To avoid this, any patient who's in their 20th week of gestation or later, or in whom the height of the fundus of the uterus is at the umbilicus or above, should be placed in a sitting position, if appropriate, or lying on their side, preferably with the hip elevated if you're having to take spinal precautions. When assessing any kind of pre-delivery emergencies, you want to take into consideration the scene size up, so take your dispatch information into consideration, and any female between the age of 12 and 50 could potentially be experiencing obstetric emergency, and this is actually becoming more spread at all times. There are pretty much, if they are having a menstrual cycle, they could potentially be having an obstetric emergency. There are cases of children as young as 9 or 10 years old starting their menstrual cycles, and women as old as in their mid to late 50s or even 60s having their cycle still. So it is possible. Go through your primary assessment. Make sure you take any standard precautions. Assess the mental status and their ABCs. Gather your history. Examine the abdominal regions and get your baseline vitals. Now, in terms of pregnant patients, you're going to hear some terms such as gravida and para. The term gravida refers to pregnancy. When a Roman numeral is added after gravida, it indicates the number of pregnancies. For example, and I'm going to use just G and P. So if I have a patient who is gravida 1, is a patient who's pregnant for the first time. This is also referred to as primigravida. Para refers to a woman who has given birth to a fetus of 20 weeks of gestation or greater, regardless of whether it was a live birth or stillborn. Para 1 would indicate a mother who gave birth for the first time or once to one or more children. If the first time mother delivers twins, they would be gravida 1, para 1, because para refers to the number of delivery events and not to the number of children. A primipara is a mother who gave birth for the first time. Go through your secondary questions. Ask them, have you ever been pregnant before? This is where you can figure out how if you're gravida as well as para. Were there any complications with your previous birth? Or with any previous complications in pregnancy? When was your last menstrual cycle? What does the pain feel like? Go through your OPQRST. What's the duration of the pain or cramps? How often do they occur? Any nausea or vomiting? Go through your signs and symptoms, such as abdominal pain, altered mental status, hypertension, swelling, seizures. And remember that pregnancy might mask early signs and symptoms of hypovolemic shock. The initial indications may be subtle or even absent, and that's because a woman's blood volume is normally increased during pregnancy, which can mask a fall in blood pressure associated with shock. Also, the mother's body will shunt blood away from the fetus and redirect it back to the vital organs of the mother. So even though the mother seems well, the fetus could possibly be in extreme distress. Provide the patient with the same care that you would to any other patient with the signs and symptoms. If they are a greater 20 weeks of gestation or more, position them to avoid supine hypotensive syndrome, and reassess as appropriate. If they're stable every 15 minutes, unstable every 5. If the mother is in cardiac arrest, continue CPR on the mother, because even if you may not be able to save her, there is a slim chance of possibly saving the fetus. Alright guys, we're going to take a break here. When we come back, we'll go over labor and delivery. So take a break, stretch your legs, get something to drink, and we'll be back shortly.